would now like to introduce our keynote for the afternoon, Dr. Andrew MorrisSinger, who is the president and co-founder of Primary Care Progress, which is a grassroots advocacy organization launched by Harvard University to promote better training and support for the primary care workforce pipeline. As president of Primary Care Progress, Dr. MorrisSinger oversees an interprofessional grassroots movement to reform primary care delivery and training. The organization has grown to over 25 chapters across the country, but still remains committed to improving the training and work environment for all primary care clinicians. In addition to leading Primary Care Progress, Dr. MorrisSinger actively writes for various blogs and news outlets and speaks regularly on the topics of primary care, community advocacy to many mainstream media outlets. In his spare time, he works as a primary care physician at a patient-centered medical home in Boston. He also teaches at Harvard Medical School. I've had the opportunity to read through some of Dr. MorrisSinger's blog posts on blogs like Kevin MD and Healthcare Blog. And one thing is evident, and the one thing that is evident from these blog posts is that Dr. MorrisSinger's passion to reform the primary care model is both genuine and admirable. On behalf of the Quinnipiac School of Law, we are thrilled to have him here. So without further ado, Dr. Andrew MorrisSinger.
Excellent. Thank you so much, Mona. It's great to be here with you all, and hats off to the organizers of this conference. Very, very cool stuff. So I know what some of you are thinking, right? This is our keynote speaker. He looks like a pre-med. But I promise you that I'm attending. I finished residency 3 years ago. I'm faculty now. And I work with one hat as a general internist practicing primary care in a patient-centered medical home in Boston near the hospital that I trained in. And then the other hat's running Primary Care Progress. My background actually is in community organizing, field organizing. Before I went to medical school, just like Barack Obama, I was a community organizer. And in my first year, we were very much focused on safe schools initiatives. And I remember my first campaign was in a town outside of Boulder, Colorado. And we were working to try and pass an anti-bullying ordinance, right? Make the school safe, right? You can't get bullied for X, Y, or Z reason. Create an ordinance. It will make change. And we had one vote that we had to get. And there was major opposition to this ordinance because it was inclusive. It included gender identity, included sexual orientation, and there was a group that didn't want those categories included. And we found one person on the committee who we thought we could change his mind, we could change his vote. And we did, because we put together a change package. We put together the data on the prevalence of bullying, the effects of it on the person who gets bullied, the bully themselves, and the environment in the schools. We put together stories of what it was like being bullied. We mobilized constituents in this guy's district to talk to him about it, and he was ready to vote for us. And I'll never forget the day of the hearing, I showed up wearing a suit. I took a shower that day. And in that 2-hour hearing, our 6-month campaign fell apart. He voted against us. And after the hearing, I was standing outside, and he left the building. He saw it was me. He motioned for the person that he was with to go away so he and I could talk. And I was just steaming. I was going to let him have it. And he came up to me, and he unloaded on me. He unloaded on me. He said, "What kind of a crappy community organizer are you?" And then he asked me, "Do you know the ratio of your supporters to the opposition supporters at this meeting? They had 3 times as many people at this meeting than you did. And do you know," and I actually didn't know that, "and do you know the ratio of their supporters speaking at the microphone to your supporters speaking at the microphone?" I also didn't know that. 2 to 1. He said, "Look, if you wanted me to do the right thing, you got to give me the support that I need. You can't just give me the ammo. You got to give me the political cover to pull the trigger." And he got in his car and he drove away. And I just remember thinking to myself, I don't want to be a community organizer anymore. I want to go to medical school where things will be easier and I'll have to work less hard and all that stuff. But I continued community organizing for 3 years, and we won in a lot of different places across the country. And what I learned is that you want to create a new law, a new policy, a new regulation, and you want to get it right. Well, 10% of it is creating the actual programming, the law, the policy. 90% of it is implementation, execution. You got to have a social strategy. You got to have a way to understand and leverage the interests of the people whose behavior you're trying to change. And I think about that all the time in primary care right now, because we have profound problems in primary care. We got problems with how we deliver care. We got problems with how we pay. We've got problems with handcuffs, preventing practitioners from operating at the top of their skill set. We've got problems with the pipeline. And the only way that we're going to be able to rescue primary care is if we, the supporters of it, leverage the interests of all healthcare stakeholders. If we use all tools in our toolkit, including the law, and engage all members of the care team. And the way I see it, all of you guys are members of the primary care team, because not one of us is immune to the disastrous consequences of our dysfunctional primary care system, the primary care crisis right now. So I'm hoping for the next 45 minutes or so we can talk a little bit, and then we can have a quick discussion. So let's talk about this primary care crisis. It's referred to by Tom Bodenheimer as the primary care death spiral, which has got kind of a nice ring to it, doesn't it? And what he notes is that we have a growing number of patients who are seeking a regular source of care. They've got coverage, they're aging, population growth, et cetera. What they're finding, though, is a dysfunctional primary care system that's not able to meet their needs. Partly it's payment, partly it's organization. It's an antiquated model that leaves them dissatisfied, rush visits, long wait times, that increasingly is utilizing the emergency department and specialty referrals at huge rates, driving up spending, making healthcare premiums that much more unaffordable to individuals, families, businesses, and government. And this model also doesn't work for the provider. It's really not fun to practice in this antiquated model. So we're burning out at increasing rates. We're leaving completely, retiring. We're being concierge docs. We're firing half of our panel. Right? We're consulting. We're leaving the practice of medicine, and we're not being replaced. As more and more the next generation says, I'm not going to work for that little money in that dysfunctional clinic with that much debt. So they've been leaving, and it just makes the practice even more unsustainable for those of us that stick around. And the next generation, who really is committed to primary care, sees this and says, I don't think so. Now, this is the aggregate data, though. And there are a lot of psychological studies, though, that show that if you really want to get someone to care about a problem, you can't present the aggregate data. You can't tell them that 6 million people have just been, whatever it is, butchered, because we don't respond to that as humans. We actually respond more when it's individual stories. So I want to tell you an individual story now about my mom. So this is Linda, and she is 61 in this picture. She lives in Jersey. She's a substitute teacher. She worked as a social worker. Hobbies include gardening, walking, and gossiping on the phone with the other Jewish mothers, also known as kibitzing. And she taught me the value of primary care. In my 4th year of medical school, 6 years ago, she was fighting for her life on a ventilator in an ICU in New Jersey, essentially because she didn't have primary care. It's not that she didn't have care. She had a lot of care. She had specialists that she went to. She had 3 specialists, ENT doc, endocrinologist, and an orthopod. But she didn't have a primary care provider. She didn't have someone that focused on the whole her, the comprehensive her. So as she started developing these nonspecific symptoms, fatigue, night sweats, just generally feeling unwell and achy, she self-referred to her specialist because she didn't have a primary care provider. None of them took responsibility for her, none of them followed up with her, and none of them listened to her lungs with a stethoscope. I know because I spoke to every single one of them in that ICU. I called them all, find out what happened. No one listened to her lungs until she showed up to the emergency department, short of breath, unable to breathe, and talk in full sentences. They took an x-ray. Both of her lungs were completely consolidated, complete whiteout. They intubated her in the emergency department, took her up to the ICU, and that's where I found her that night. And when I arrived, they knew that I was a medical student, so they told me that they weren't going to lie, that they had never seen someone with this much lung pathology survive in that community hospital ICU. And would I give my permission for her to have Zygris, activated protein C, because she had ARDS. She had acute respiratory distress syndrome, where your lungs are so inflamed, they have so much fluid in them, that they literally can't ventilate and oxygenate on their own. You have to force incredible pressured air to make it happen, which can kill someone. I gave permission, and that began a 6-week nightmare roller coaster. Now, she ended up surviving. It was miraculous. I mean, somebody was on her side. And this picture was taken about 3 months after she got home. If you look closely, you can actually see the tracheostomy scar in her neck. And to her credit, you know, she uses this experience to her benefit. She was recently up visiting us in Boston, and she was watching TV, and she said, "Andrew, can you pass me the remote control?" I'm like, "Ma, it's right there in front of you. Can't you grab it?" She said, "This is how you talk to your mother who had ARDS? What do I have to do to get a response from you? Get some more pneumonia?" I said, "Ma, actually, there is no R at the end of pneumonia, or diarrhea for that matter." So, but during those 6 weeks, one thing that I couldn't stop thinking about was the fact that despite the fact that my mom and millions of other Americans were suffering catastrophic healthcare consequences because of access problems to primary care, I was at a medical school that was actively discouraging people from going into primary care. That was actively telling people, "Hey, you seem smart. Don't go into primary care." Or, "If you wanted to go into primary care, why did you come here?" And when I went on the rotations, it was predominantly in the hospital, glorifying the invasive procedures, the subspecialists, and denigrating primary care. And then when I got out into the primary care practice, it was frequently a letdown because they were some of the most dysfunctional models. And soon I would learn, though, that I was just seeing the tip of the iceberg in terms of how much of an afterthought primary care had become in our healthcare system. So, one of the panelists earlier talked a little bit about this, but I've got some visuals on this. We've been underinvesting in primary care for decades. So health economists basically believe that a healthcare system should be designed to serve the needs of the population. If you look at your average population, our healthcare needs are represented by this pyramid. At the bottom, which is what everyone needs, is basic wellness and primary care. Right? We need vaccinations to prevent disease. We need exercise, nutrition advice to stay healthy. We need frontline primary care to address the common problems that most Americans have and prevent them from going out of control. It's only a small percentage of us that require secondary care, right? Who are complicated enough that we should see a specialist for another opinion or for an invasive procedure. And it's even a smaller fraction that require tertiary care at the top of that. In-hospital treatment, invasive procedures for incredibly rare conditions. But if you look at how our healthcare system is actually organized, if you look at the intellectual, the financial, the personal, the infrastructural investment, it predominantly goes into this tertiary and quaternary care, with primary care as an afterthought. We spend 17% of GDP in this country on healthcare. Less than 5% goes to primary care. Less than 5% of healthcare spending goes to primary care in this country, despite the fact that every single one of us needs it. And we're feeling the effects of that. 1 in 5 Americans doesn't have access to a regular source of primary care. And health economists believe that this is a major reason why our spending is completely out of control. And yet, for all we spend, we get relatively poor outcomes, right? Our mortality rates, infant mortality, overall health is worse in every age group. This is bad value, right? If we pay a lot and we get little, that's bad value. And we hate getting bad value in this country. If there's anything we despise, it's getting bad value service. Can you guys recognize this? Can you guys see this? Do you guys remember what this is? This is a commercial that played in the 80s. Very popular. Can anyone see it and recognize it? Say it louder. And what is he saying?
He's not happy. I can't exactly remember, but still.
Help her out. What's this guy saying? What's this guy saying? I'm not going to pay a lot for this muffler. This was one of the most popular 80s commercials, right? And I mean, was it because we all were afraid that we were going to pay a lot for the muffler? I mean, who here who was around in the 80s bought a muffler in the 80s? Raise your hand. Okay, so just a few of us. I think what was so popular about this is we have this innate fear about getting screwed over in this country, right? We don't want to pay a lot for this muffler. I mean, literally, to this day, when we're shopping, when we're at Best Buy, when we're shopping online, we're walking around muttering under our breath, I'm not going to pay a lot for this muffler. Right? But friends, we have paid a lot for this healthcare muffler, and we don't have a ton to show of it. You can get some of the best late sick care in this country, the best. But if you got diabetes, you got a 50% chance that you're not going to receive recommended care. Stuff that we've known for decades saves lives, saves eyes, saves kidneys, saves limbs. And one of the reasons that's that case is we have not only underinvested, but we haven't organized our services. So think for a sec about all that we have to do in primary care, right? We've got to address acute problems, headache, belly pain, stuff that comes up. We've got to manage chronic disease, hypertension, diabetes. We've got to prevent disease in the first place, vaccinations. We've got to catch things early through mammography, colonoscopy, and then we've got to coordinate all that care. But we've never figured out a way of organizing this. We've never done what every other sector of society has done in terms of think about the service that we provide and come up with the most effective, efficient, patient-centered, sustainable model of delivering that care. We've never devoted the intellectual resources to that. Put another way, we've never figured out how to do the right care for the right person at the right time in the right location in a sustainable manner that's not going to kill our society. Instead, we have used an antiquated model of delivery where the provider is in the middle and he or she is trying to do all of this stuff, him or herself, right? All that stuff, acute, chronic disease, care coordination, screening, and it's impossible. It's an impossible task. And what it leads to is not only poor quality of care, but it leads to something happening to us providers. Yarnell, in 2009, did a study basically saying, if we took your average primary care provider with your average panel size, and we looked at all the stuff that should be getting done and figured out how much time that would actually take, for them to do all acute, chronic, care coordination, cancer, screening, all that stuff, it would be 21.7 hours a day of work, every day, no weekends, no holidays. And friends, we know what happens when it's all work, no play, every day, all day long, right? We snap. We snap. And this, friends, is what a lot of medical students and other health professional trainees see when they come to rotate with us, right? Hey, Jesse, you're the medical student working with me today. Great. Why don't you put your backpack there, get started in room 5, and I'll just be in my office blowing my brains out. So this is one of the reasons that we're having such a problem in the primary care pipeline. But this is also one of the reasons why patients are really feeling that our system's not meeting their needs. And I want to tell you about a guy in particular. This is Mark. And the reason I show this slide is Mark is someone I take care of, and his whole life has been about his job, which is driving car services. And I met Mark 2 years ago. He's a 62-year-old guy from New Hampshire. He comes right over the border to Massachusetts to get treated. And he's got this thick stock of white hair, big rosy red cheeks, and his favorite movie is What About Bob? And that's perfect because my favorite movie is about What About Bob? So we're like constantly doing What About Bob jokes to each other. Now, Mark's got a lot of medical problems, and that's one of the reasons he came to our practice. So he's got diabetes that's been out of control for years. And so it's left him with kidney problems and with nerve problems in his legs. He's got diastolic heart failure, so his heart doesn't squeeze normally, and all that fluid backs up into his legs, and he's got big legs that frequently fill up. We got to send him to the hospital. He's got spinal stenosis, so his spine is encroaching on the spinal cord, leaving him in chronic pain, for which he's on tons of narcotics, which have their own side effect profile. He's got vitamin B12 deficiency. He's got diabetes, I'm sorry, not diabetes, depression, and severe anxiety. But on top of all of that, and the 21 medications he was on, when I first met him, he was having these drop attacks. So you get this heat sensation on his chest, and then he would drop. He would syncopize. He would go out. And if you want to freak us out in healthcare, you do that in front of us, right? We freak out when you do that. We code you. And then we send you into the hospital. You go to the emergency room. You go to the floor. They do every single test to you. This kept happening to him. In a few months before I met him, he went to the ED 10 times. He was admitted 4 times. And they did every single test you can think of to him, but they couldn't figure it out. These kept happening. They were happening in increasing frequency. He couldn't drive anymore. It got to the point where he couldn't even really walk his dog. He couldn't even leave the house. And you can imagine his depression and anxiety just were off the charts. And the problem was that Mark was receiving a lot of care, but he was receiving the wrong care in many ways. And in the week before I actually met him, as I was doing the chart biopsy, reading about him and preparing to meet him and sweating, seeing all the stuff that had been done to him, I realized that he is the poster child for our dysfunctional healthcare system. I mean, here's this guy who represents the 5% of patients that account for 50% of healthcare spending because of how complicated they are with their medical and psychosocial comorbidities, who's receiving care in this fragmented, dysfunctional healthcare system where the left hand doesn't know what the right hand's doing, where people aren't communicating, where people aren't following up. And he's having his care managed by this lone provider, this physician who's trying to do everything himself, because that's the only option, within the confines of these small 15-minute visits, right? It's a perfect recipe for poor health outcomes, unhappy patients, spending up the wazoo, and unhappy providers. But when Mark came to our practice, he found something new. Cue inspirational music, right? The sun comes through. He met our practice. So our practice was designed by this guy, Stuart Pollack, a year before it actually kicked off as a patient-centered medical home, because Stuart was basically practicing in an antiquated model of care and realized that it was it. That was it. He was either going to retire or he was going to start something new. So he came to Brigham Women's Hospital. He convinced them to launch a medical home, heavily invest in the team, new members of the team, having everyone operate at the top of their skill set, and we launched. So when Mark came to our practice, he met the members of Team 2. The first person he met that day was Sonia, the pharmacist on our team. Now, Sonia was not behind some counter dispensing medication. She was sitting there in the room going through his 21 medications, helping him understand which one did what, when was the best time to take them, right? Which ones not to take at the same time. She also took his diabetes management off of my plate, right? He checks his sugar. We have to figure out how we should change his insulin. She was now in charge of managing that, which was huge. The second person Mark met was Sarah, our social worker. Sarah and I literally sit side by side, right? And she's there helping me manage his depression and anxiety, which was severe when he first came to us, helping me connect him to the right community resources, things I didn't even know about, and when things got out of control, helping bridge him to more intensive psychiatric services. He met Leslie, our nurse care coordinator, who could not only help him and ensure that he understood what we were talking about, understood the directions, understood that, which specialist he had to see, but was literally on the phone with him every day. As these small symptoms would develop, right? The pain was out of control, his legs were getting a little bigger, his weight was going up. She was responding in the moment, keeping things from snowballing out of control, which would require him going back to the hospital. He met Jennifer, our physician assistant, who, because she and I were working so closely together, she could help manage this incredibly complicated patient right? This severely complicated patient. And then finally, he met me and my manicured hand there. And what he found was a personal physician who, because other members of the care team had taken on not only tasks but responsibilities, I was able to operate the top of my skill set. I was able to focus on what I was trained to do, which was essentially make some of the difficult diagnostic and management decisions, coordinate with all the specialists, and continue to build that physician-patient therapeutic relationship. Within 4 months of Mark coming to this practice, we discovered two critically important things. Number one, Mark was hypogonadal, meaning he had low testosterone. It was the one test that they didn't test out of all the different things. Mark was having these drop attacks because he had low testosterone, and when we chucked a testosterone patch on his shoulder, his drop attacks went away. His drop attacks went away, he got back to driving. Second thing we discovered, he told Leslie one day on the phone when she was talking about his weight, he said, "Oh yeah, by the way, I'm just a raging alcoholic. I don't drink on the road, but I drink when I get home, and this has been going on for 30 years. And wow. With Sarah's help, we got him into detox. We got him into AA. He stopped drinking. Guess what happened to his blood pressure when the alcohol was gone? It came down. Guess what Sonia did with all his blood pressure meds? She got rid of them. So with this team-based approach to primary care delivery, we not only got Mark his life back, we not only got his wife, her husband back, we not only helped the payers stop literally burning through money, but we created a system that we could actually sustain, a model of comprehensive primary care delivery that we could do day in, day out for all of our complicated patients like Mark. And the reason that this works is because we're all operating at the top of our skill set. We're sharing the myriad of tasks that compose what someone needs. And it's not just for the person right in front of us, it's for all of our patients. And we're not just waiting for patients any longer to call us and say, "I'm having a problem," or "my sugars have been out of control." We're reaching out to them proactively, and we can do that now because we have the data. Because the data enables us to know not only who our patients are, but what conditions they have and how well those conditions have been managed and what else we should be doing. And now the data is being pushed into the primary care space where super-empowered, kick-ass teams are able to harness that data, be held accountable to it, and do something about it. And it's producing a lot of wonderful things. So the medical home is basically the space where we are doing this redesign of primary care. And how many of you have heard about the patient-centered medical home? Great. Keep your hands up for a sec. How many of you work in a patient-centered medical home? Okay, excellent. The basic concept of the patient-centered medical home is it's a covenant between the payer and the provider about what constitutes high-value patient-centered primary care delivery, right? If the payer is going to pay more for this, we've got to actually certify something and say, this is it, this is the ticket, this is the hot dog of primary care. So there's some basic ingredients, right? It's team-based care, comprehensive care, enhanced access to care, right? Not just the face-to-face, but also telephone and email. Continuous quality improvement because we've got robust information technology. And this is taking off across the country. More and more systems are adopting this model. This is a campaign we ran a year ago where we asked people who are working in patient-centered medical homes to share why they love this work so much. Literally, we're hearing stories about this model pulling people back from the brink of retirement. And it's spreading to different systems across the country as they adopt it. And the initial data is incredibly promising. We're seeing improved quality of care in a bunch of disease measures. We're seeing enhanced access to care. We're seeing reductions in emergency department utilization and hospital rehospitalization, and all of this for lower spending, 9% lower spending in certain studies. So it's no wonder why payers are purchasing patient-centered primary care right now. Payers have been getting killed by our current healthcare system. The rate of growth in healthcare spending by your average large payer is unprecedented, it's unsustainable. It's making it so these companies can't compete, they can't raise wages. A car in the United States costs $1,000 more than produced in other countries because of healthcare costs. But it's not just private payers, it's public too. The Department of Defense, the VA, Medicare, Medicaid. Our budgets are getting busted because healthcare is so out of control. And so these groups have not only realized that they can't sustain this anymore, but they've realized something more important. They've realized what we've known for a long time, that primary care creates value, that those areas of the country with higher levels of primary care have overall better quality of care, lower spending. And they're starting to realize also that more care isn't always better care, and that specialty care isn't always better than primary care, and that inpatient, hospital-based, technologically enhanced, robotically advanced care is not always better than proactive outpatient health coaching, right? And they're realizing that if we provide more upstream care, we can avoid downstream sick care. We can avoid butts in beds. But I think the most important thing that they're realizing is that they can leverage their financial muscles to get what they want, in the same way that they do with other vendors of services that they utilize, right? The people that make the widgets that they use in their TVs, whatever it is, if they're getting a quality problem, if they're getting low value, they leverage their muscle. They say, you know what, I don't want to buy this anymore from you. If you're not going to produce something better, we're going to go elsewhere. And that's literally what they're doing. These companies are investing in patient-centered medical homes. They're divesting from health systems that don't provide a robust foundation of primary care. And we're seeing this across the board. We're seeing this from large corporations like IBM, Whirlpool, Boeing. In fact, 25% of the largest corporations in this country are investing in on-site or near-site patient-centered medical home delivery right now. We're seeing this at the state level. Vermont, Maryland, Oregon, massive, massive investment in primary care infrastructure, workforce development. They're committing to creating a robust foundation of primary care for everyone. The Affordable Care Act. There's only one group of providers that saw an increase in their payments. It's primary care providers. And we're also seeing this from the third-party payers. Aetna, WellPoint, they're increasing payments, per member per month fees, care coordination fees. It's pretty cool, right? It's not enough, though. 3 months ago, Stuart, our medical director, took the physicians aside. He brought us into the kitchen, he sat us down, and he pushed these pieces of paper to each of us. And on those pieces of paper were our productivity, our RVUs, and basically our billable services. And he told all of us, the 7 docs in the room, that we were all on track to get a 20% pay cut. Despite working 3 times as hard, despite improving quality of care, despite reducing admissions and rehospitalizations, despite improving patient satisfaction, we were all going to get dinged. And we were all going to get dinged because we were ahead of the reimbursement curve, right? We were practicing in a model that was financially unsustainable in the current model of fee-for-service reimbursement. And I got to tell you, that meeting was tough. I mean, you know, we're a 7-person doc practice. We have 30 people in the practice. We have a bunch of PAs, a bunch of nurses, 7 docs, like I say. But our physicians are early career folks. They're 2, 3, 4, 5 years out of training, because we really believed in this model. And here we are being told that despite committing ourselves, slap in the face. And I just remember one of our physicians started crying there, basically saying, what do we do? You see, despite being the right thing to do to have Sonia manage Mark's diabetes, we couldn't get paid for that. And despite being the right thing to do phone visits and email encounters with Mark so you didn't have to drive down to Boston to tell us what was going on, we didn't get paid for that. And despite being the right thing to do for our team every day to find time as a team to talk about who are our most vulnerable patients, who is going to probably end up in the ED, who should we reach out to, and who's going to do the reaching out, that was taking time away from those face-to-face visits, which was the only thing that we got paid for. And friends, we are all victims to this fee-for-service model of reimbursement right now. And one of the physicians earlier talked a little bit about fee-for-service and the ruck, and I'm going to dig in a little bit here because I just think it's so important that every single person understand what we're dealing with here. So fee-for-service, right? You get paid for volume of services, not value, right? So you do something, you get paid, whether or not it was indicated, whether or not it was necessary, whether or not it was harmful. And when you pay in that way for widgets, essentially, you're guaranteeing a certain amount of unnecessary care in the system, right? You're basically baking it in. It will be there. And health economists believe that 1/3 of healthcare spending right now is totally unnecessary care. I mean, think about that. 17% of GDP is spent on healthcare spending. 1/3 of that is unnecessary. Think about all the social programs, educational, environmental, public transportation system things we could be doing as a society with that money. Or if you don't believe that, think about all the bombers we can be building, right? All the Humvees we could be up-armoring. Whatever it is, we could be doing something with that money that we're just wasting right now. So if that's not surprising enough, though, let's talk more granularly about the fees for these services. So as the physician before was talking about, the RUC, the Relative Value Update Committee, was created by Congress with the help of the American Medical Association to give recommendations about the value of medical services in this country. And that group is composed of about 30 people, give or take a few, of which only 3 to 4 are actually primary care docs right now. And I encourage all of you to learn about how the sausage is made with our healthcare services right now, because it is wild. So, as we heard about before, they assign value to each of these services based upon risk, costs, equipment, so on and so forth. As new services come online, they're supposed to revalue them. As services that have been done for years become easier, less risky, right? Less costly, they're supposed to devalue those services. That's the theory. Well, a couple things about this group. Number one, it meets behind closed doors. They sign a confidentiality agreement when they go in. There are no minutes from these meetings, so there's no public accountability whatsoever. We have no idea what is going on in that. Secondly, where do they get these actual values from? How do they come up with them? They send out surveys to members of their specialty societies, asking them, with a non-objective survey, how much time does it normally take you to do a colonoscopy? And what's the cost of maintaining your colonoscopy equipment? Well, that would sound fair, but the fact is they've done studies that show that there are massive discrepancies between what some of these folks report in terms of time that they're doing these procedures, right, time it takes, and the actual operation room logs. Massive discrepancies. So that's how these fees are getting determined. And over the years, what we've actually seen is most of the updates to these fees have been revaluations that push values up. So as a new service comes online, right, it gets valued, and it's usually pretty high because, as we talked about before, values for inpatient, procedural, highly technical services are much higher than the evaluation and management services that are basic bread and butter of what we do in primary care. Additionally, we don't even get value for certain services that we do on a day-to-day level in primary care. Care coordination, we do not get paid for that. It's not considered valuable at the present moment. But over the years, what we've seen is this group usually pushes values up. Very rarely will they devalue a service that's been around for a decade or so. So what this has essentially done, and I know I'm harping on this, but what they've essentially done is the distance between payments for specialty services and primary care have just gotten bigger and bigger and bigger over the years. And if it sounds like I'm telling you that we're getting milked, it's because I'm telling you that we're getting milked. So, we've got to do something about this, and you guys are going to help us do it. The problem is, though, that in the meantime, this approach handcuffs us to this antiquated model of care. Because the fees are so low, and because we only get paid for certain types of services, we're on a hamster wheel right now, right? This is the reason why it's very hard to do team-based care, because a lot of the things that other members of the care team do, they're not compensated. This is the reason why I got to force patients to drive 60 miles to be seen, because I don't get paid for that telephone encounter or that email encounter. And if I substitute too many face-to-face visits with those non-face-to-face visits, I'm at risk of going out of business. And it's also the reason why we have to run, literally run from room to room, because we have to smash a ton of these 15-minute encounters into the day in order to cover our overhead. And literally, if you talk to medical students these days, they'll tell you that they see the clinicians running from room to room. So we've got to get away from this fee-for-service reimbursement model. And there are a lot of different proposals on the table, but we're going to need the political cover to push them forward. So friends, I think I am painting a picture for you that, it hasn't been easy being in primary care for a long time. And, look, a lot of you have been in primary care a lot longer than I have. I mean, you guys have been doing this back when I was pressing A and B buttons and listening to Iron Maiden. Any Nintendo fans out there? All right, good. But this difficulty has left a legacy for us. And I remember when I finished residency and our organization, Primary Care Progress, had just launched, I went to visit with my colleague, Shoma Stout, who's a clinician at Cambridge Hospital. And I was looking for recommendations. Shoma, I'm launching this nonprofit, but I need a place to see patients. What do you recommend? And she said, oh, you should be the medical director at Revere. And I said, Shoma, what are you talking about? Medical director? I'm green. I just got out of residency. I'm a general internist. I'm better at managing a patient on a ventilator than responding to a rash. What are you talking about? And she just said, Andrew, don't you get it? There's a lost generation of primary care doctors, practitioners, and leaders. They didn't come in. They left early. They fired themselves. There's a huge opportunity to just step in and step up. And I really think that's true, friends. We have been hemorrhaging people from the primary care pipeline for years. It used to be that 40 to 50% of graduating medical students, in this instance, going into primary care. Now that's less than 20%. And you're probably saying, wait a second. We just saw match numbers. The match numbers went up, right, for primary care. And I just saw this dean's statement that 40 to 50% of their med school class went into primary care. What are you talking about? That's what we call the dean's lie. Have you guys heard of the dean's lie? Yeah, so what the deans are doing is they're basically saying if you go into internal medicine residency, family medicine residency, or pediatrics residency, you're our future primary care doc, right? Problem is that only 20% of internal medicine residents actually go into primary care. Only 40% of pediatrics residents go into primary care. So calling medical students that go into internal medicine and pediatrics our future primary care docs, it's like calling a carton of eggs future chickens, right? It's not true. And we have to get our academic leaders to own this hemorrhage from the primary care pipeline. That's multifaceted. It's not completely their fault, right? We talked about the low pay, $3.5 million of lifetime revenue someone is walking away from when they go into primary care these days as compared to a subspecialist. That's going to change, but that's the way it's been. And that's a hard decision to make when they've got, on average, $140,000 to $200,000 worth of debt, which we call the golden handcuffs. We're also getting discouraged, the hidden curriculum, right? Kids walking around with shirts that say, friends don't let friends go into primary care. You've seen it, right? And then finally, antiquated models. They're rotating through practices that almost seem like they were designed to destroy an interest in a primary care career. And then on top of that, we're not even recruiting some of the students who are most prone to being primary care clinicians. The rates of bringing in folks from rural areas has dropped by 50% in a decade. That's crazy. So these folks are not coming. And you're probably wondering, do we have any leverage? Do we have any leverage with these academic institutions to turn out what this society needs? And the answer is yes. We have billions and billions of dollars of leverage. Medicare, tax dollars. Right now, we pay, in taxpayer money, $500,000 per resident to educate them. And yet, there is not one string attached to those dollars. A hospital gets the same amount of money if they have a neurosurgery residency spot or if they have a family medicine residency spot. And the incentive is therefore to get rid of the family medicine residencies and to have more subspecialty residency spots. And that's actually been the trend. And our efforts, the government's efforts, to try and remedy that have been fairly weak. In 2005, we tried to reapportion some of the unused residency spots and get them to go to rural and primary care positions. But it was weak language. And what ended up happening was we just saw that many more residency positions going to subspecialty training and away from rural counties. So we've got to get Congress to take the bull by the horns and really hold graduate medical education accountable, or we're just not going to have the primary care practitioners that we need in this country. So a lot of people wonder, is our healthcare crisis too big to fix? And I got to be honest. I mean, you know, there are a lot of moments when I wonder about this. I was having dinner with a friend of mine that I trained with, and she's a general internist too. And she, you know, she's a practicing primary care doc now, and we had a drink, and so she got honest. And I just remember she put her head in her hands and she said, Andrew, I didn't go into primary care to advocate for it and to transform it. I went into primary care to practice it. And yet, I have to do all three of these things, and it's so tiring, and I'm so young, and I'm so ready to quit. And that is a common sentiment right now. It is a tough moment, I think. We have amazing opportunities, but we also face huge challenges. But, you know, I think we have to step up because no one else is going to. And if we don't step up, others are going to step in. And none of us are going to be happy with what ends up happening. But we don't have to start from scratch, right? There are so many awesome things going on right now in the primary care space. We've got new models of payment that are being coupled to new models of delivery. And these are taken off around the country. Comprehensive Primary Care Initiative has $10 billion worth of funding of these pilots, and where they're happening, they're making a profound difference in the life of the clinicians. We've got new state efforts, right? Coalitions that are committing to primary care in fascinating ways. You should read about what the governor of Oregon just did in terms of committing his state to really redesigning the healthcare system around primary care. These initiatives are going to make primary care happen in a much more high-value way. We're seeing student activism, right? We're seeing coalitions of students and other trainees coming together at academic medical institutions with our organization, Primary Care Progress, AMSA, Family Medicine Interest Group, right? All of these groups basically using grassroots approaches to getting schools to take primary care programming more seriously. And the faculty are doing similar stuff as well. Learning collaboratives, where faculty are working together around the country to transform practice and push it forward. And finally, we're starting to see movement in DC, new bills, new conversations, new discussions where we're going to start holding graduate medical education, the RUC, accountable, right? There are new things that are happening to rein in some of the absurd excesses of our fee-for-service, primary care denigrating payment system. And we could talk a little bit more about that if you guys are interested. But one thing is not happening that we need to spend a second talking about. Who's the one group that's not up there? Patients. That's right. Patients, I believe, as a community organizer, are one of the most under-harnessed constituencies when it comes to healthcare reform right now, right? The patient-centered medical home is not the patient-centered medical home. The patient-centered medical home is the physician's perception of what patient-centeredness is. But when patients actually see it, they're like, that's not what I want. I don't need that. right? But this is what I want. So we have got to figure out a way as a community to start engaging patients, to start helping them understand what we're actually talking about. Because have no doubt, friends, 17% of GDP is spent in healthcare right now. Think about all those individuals, groups, and interests who are committed to keeping the system exactly as it is. What do you think they're going to be willing to do to defend that? What do you think they're going to be willing to say about our new model and us to defend that? Just picture death panels if you have any question in your mind of the depths that people will descend to protect what they're scared of. So we've got to come together, we've got to engage patients, and we've got to ensure that they understand what this is about, that they're advocating, right? That they're talking to their friends, their families, their colleagues, their legislators about the importance of this. That's something that we can all do together. And we really need to see the primary care boards come together on this in a very substantial way. But something else, though, that I think we have to do more of, but we're starting to see some of, is we have to start talking differently. We've got to start messaging ourselves and the situation in a more effective manner. And if you look at the way that primary care people, primary care supporters have talked in the recent past, what we've done is that we're trying to get other people to care about the problems that are affecting us, right? We're trying to get people to care about the fact that family medicine divisions are being closed and nurse practitioner scope of practice laws are encroaching on us, right? And that this medical school is not committed to primary care output. But we've failed to get other people to care about the problems affecting us. And so we worry alone, and we stress alone, and it doesn't have to be that way. There's a story of this guy named Alan Blum, who comes home one night, late at night, and he walks into his apartment, and he gets a little bit of bite to eat. And he's about to go to bed, and he sees the light under his oldest son's door. And he walks up the stairs, and he knocks on the door, and there's no answer. And he opens the door, and he finds his son in the room, pacing back and forth, ashen. And he says, "Son, what's wrong?" And his son says, "Oh, Dad, you have no idea. You know that Danny Weiss across the street? I owe him $6,000. I owe him $6,000. I have to pay him at 8 a.m. tomorrow morning. I don't have the money. I don't know what I'm going to do." So his father listens, and he says, "Is that it?" His son says, "Is that it?" "Of course, that's exactly it. There's nothing. I don't have the money." And his father says, "Okay, sit." So his father walks over to the window, hooks it up, he leans out, and he says, "Hey, Danny Weiss, this is Alan Blum, Jared Blum's father. Wake up! You know how he owes you $6,000? And he's got to pay you tomorrow morning at 8 a.m.? Well, he doesn't have it. He doesn't have a cent of it. You're not getting paid." And he closes the window. And he walks back, and his son says, "What the hell is wrong with you, Dad?" And his father says, "You don't have the $6,000. Why should you stay up all night worrying about $6,000 that you don't have? Let Danny Weiss stay up all night worrying about this money, and you can go to sleep." And friends, we've got problems in primary care. We really do. But they pale in comparison to the problems that our patients have getting access. They pale in comparison to the problems of corporations, which are going out of business. And they pale in comparison to the problems politicians are facing with Medicare budgets, Medicaid, right? With their constituents coming to them and armies saying, "What the hell are you doing about our access to primary care?" We've got to stop talking about the problems that affect us and start talking about the problems that affect other people, because that's what they care about. And the most effective primary care people right now, if you watch what they're doing and watch what they're saying, they're talking about those problems. and people are listening. So I think that this is an amazing moment in primary care. I think more and more of us are realizing we are not small, we are incredibly valuable. We're starting to wear our value proposition on our sleeves, and we're starting to understand that, you know, to get out of this healthcare crisis, primary care is our society's best bet. Best bet. And so I think it's wonderful that you had this conference. I encourage you to have it again next year. And I would make one small change, though. I would just change the title to this. Because I think that's where we are these days. Thank you very much. So happy to discuss, questions, push back, tell me I'm crazy. If there are any specialists in the room, now's your time to come punch me in the face. Yeah, please. Well, you know, you're actually the expert here, so I'm going to end my question by saying, but tell me what you think. But I think it has an incredibly important role. I mean, look, there's a practice in Las Vegas called Iora Health, and it's run by this guy named Rashika Fernandapule, who's done incredible things getting off the grid, contracting with a local union, so they're no longer being paid fee-for-service. They're being paid capitated. They're being given lump sum to take care of all their employees, so they've been able to blow up their approach to healthcare, right? And when I went to speak to Rashika, and I said, Rashika, you know, we're trying to build the pipeline here. What type of, you know, clinicians do you need? How many more physicians? How should we get them prepared? And he said, Andrew, I don't need more physicians. I need more health coaches. Can you turn out more health coaches? And the reason I say that is because I think once we get untied from some of the antiquated models of payment, I think it's going to really help us understand what patients do need, what they don't need. I think we're going to be getting a lot of care out of the office into the community. I think we're going to be engaging other members of the care team. I think we're going to be engaging family members, because I'm hopeful we can actually start paying them too. And I think mobile technology and apps is going to play a huge role. I mean, look, Kaiser, 40% of their interactions with patients now are, you know, asynchronous. So I think it has a huge role to play. But what do you think?
Well, I think you and I can talk more about that later. But
Okay.
I mean, I certainly I agree. And
Yeah.
you know, in fact, I didn't get to talk much about you know, our business specifically, but our platform is based on this idea of collaboration. It's not just two-way between a patient and a doctor, but it's about being able to include you know, the other members of the team, which includes family.
Yeah. Absolutely.
And we've started in pediatrics, which makes it necessary to include family because patients are not self-sufficient.
Yeah.
But I think that model applies across the board.
Absolutely. And I think technology also is going to enable us to really help specialists operate at the top of their skill set in a form of Project Echo. I think Project Echo is an amazing example of what we can do as a full care team. Other questions? Yeah, please.
I'm just curious, you know, you said you were going to take a 20% discount from your salary for all 7 of you.
He was paying attention.
And, you know, I work in rheumatology, so any discount is enough to make our hair raise, and I don't have much left. So I'm just curious, being ahead of the curve like that, how did you resolve or try to resolve where you stood at that point?
Yeah, no, it's a great question. So we had a very difficult conversation. We literally, it's like one of those conversations where all options are on the table, right? We even talked for a few minutes about Botox. I mean, it was not a fun experience. But what we ultimately realized is that we had a ton of no-shows. And if we could redesign our workflow, we could actually cut down no-shows considerably. We also had to stop substituting some of the face-to-face visits with email and phone. So we actually had to do a lot more of the email and phone on our own time. So we ended up not getting the cut, but it just meant we had to all work 4 times as hard as opposed to 3. But I mean, this is a phenomenon that is going on across the country, even in systems that are now medical homes that are actually receiving maybe even up to 50% of their fees being, capitated. The average provider is still seeing fee-for-service motivations. They're still largely productivity-based, and so the hamster wheel is just going faster. There's a question over here. Yeah, please.
Do you have any thoughts on how the Affordable Care Act may impact your primary care practice?
Our practice in general, or all of primary care?
Well, why don't you start with your practice?
I think we're going to probably see more patients, and that's going to reduce access for everyone. I think that some of the meaningful use stuff depends upon who you talk to, but a lot of clinicians are telling me, and I spend a ton of my time on the road, that it feels very meddlesome right now, and it's actually handcuffing them to the computer even more so than in the past. It used to be that front desk staff member could actually order labs. That's no longer the case. And so what that's requiring is the clinician, the physician assistant, the doc, the nurse practitioner, now has to put in those orders, and it's just one additional thing. In the grand scheme of things, the Affordable Care Act, I think, is just going to, I think things are going to get worse before they get better. I think it's forcing the shortage of primary care health professionals that we have. I think ED overcrowding is going to go up the wazoo. I think more states are going to see ambulance diversions, and I think a lot of people are going to be unhappy. Yeah, please.
One of the things that you may not have mentioned is, what is the ownership structure of your organization?
Right. So I work for Brigham and Women's Physician Organization, and the practice is a part of Brigham and Women's Hospital, the primary care division. So we got started in a lot of ways because Brigham and Women's decided to really invest in us and subsidize, using our practice as a pilot to see.
501c3 or profit?
That's a great question. I'd have to get back to you on that. I'm not very involved in our practice structure or the administration. I just see.
Maybe you should be, because that might affect that 20% next year.
This is a good point. This is a good point. Yeah, please, Lynn.
I just wanted a little bit more information about the pilot, speaking of all the reimbursement issues. That national pilot that's going on, is that trying to pay for some of these things that are very different than what we already do?
So the different pilots, yes. So it's happening in different states. We're seeing this with Medicare. We're seeing this with Medicaid. We're seeing this also with some of the privates, that they are increasingly paying care coordination fees. They're paying per member per month. Let me say that again. Per member per month payments as well for these different practices, and it's enabling these practices to start investing in some of that, other ancillary members of the team, health coaches, that sort of thing. The problem is, though, we don't know how long this is going to last for. Right? I mean, Medicaid rates are being brought up to Medicare levels for 2 years, but a lot of practices are saying, well, I've got a grant to hire a nurse practitioner as a whatever it is, care coordinator, but that's just for 2 years, and is the money still going to be there? So there's a lot of stress right now amongst providers and systems about are we going to end up like that wolf, hanging over the cliff with the floor falling out from under us. One more question, because I know we have to get going. Last word? Yeah, please.
With all the pilot programs and demonstration projects going on with Medicare and bundled payment services systems and the ACOs, and there's so many different things that they're piloting, do you see any one or two of those holding more promise than another?
Ooh, that's tough. Yeah, I think it's too early to tell right now. I mean, it's a difficult moment for us, because if we're being honest as primary care health professionals, what we'll tell you is that the data about medical homes producing all this amazing stuff, it came from a very self-selected group. It came from a group of people that said, I want to be an early innovator. I've been wanting to do this my whole life. Finally, you give me the tools, I'm going. But what about the rest of us? right? What about the rest of the practice who are like, really, I have to do that? I'm like 5 years away from retirement. I have to sit next to the health coach? Ugh, right? So what is it going to take to get them? And that's a big question mark. What's it going to take to help them in terms of payment, in terms of teaching, but are they going to be able to deliver the same results? It's a big question.
Like the PQRI and then when it became PQRS. I mean,
Yeah.
at first it was an incentive and then it's turned into a penalty.
Right.
And it seems like a lot of the programs start that way with an incentive and then become a penalty for non-participation.
Yeah, no, it's, I don't know. We shall see. But look, I mean, Don Berwick says there's no one right answer to any of this. And that's why we have to do everything. And one final last visual. There's a moment in Saving Private Ryan where the Marines are getting off the boat. They're getting onto Omaha Beach. It's the most dangerous beach of all the D-Day landings, right? 50% casualty rate. And they're just getting flogged. And they're in the water, and Tom Hanks is standing there, and one of these corporal comes up and says, "What's our rally point?" And Tom Hanks just turns to him and says, "Anywhere but here." And I think in some ways that's what we're dealing with in primary care. Where are we going? Anywhere but here. Right? We got to move. We got to go. This isn't working. And that's why I think we're going to see in a few years what actually does work. But people on the ground are doing amazing things. I just came from North Carolina where they have a learning collaborative. Family medicine, internal medicine, pediatrics coming together to describe what they're doing in their practices, best practices. They're constantly learning, oh, you do it that way, we should do that. Oh, that's brilliant. That's what this is about. Thank you.